Potassium haemostasis. The normal potassium level in blood is 3.5 to 5 milliequivalent per liter, or 3.5 to 5 millimole per liter, as the conversion factor is 1 between milliequivalent per liter and millimole per liter of potassium. Potassium plays a vital role, especially in a cardiac electrical conduction. Potassium also plays an important role in muscle and nervous tissue excitability. The normal distribution of potassium. In a 70 kg man, there is a total of 4,000 milliequivalent of potassium, in which only 1.5% or 60 milliequivalent is available extracellular, while the vast majority, which is 3,940 or 98.5%, is available intracellular. The lab results of potassium reflect the extracellular of potassium, not the total potassium available in the body. Since potassium is mainly intracellular, any maneuver that results in the release of a small amount of intracellular potassium will erroneously raise serum potassium. These might include tight tourniquet, vigorous exercise of extremity during blood drawing, hemolysis due to vigorous shaking of the test tube, thrombocytosis, and leukocytosis. Western diet contains 50 to 100 milliequivalent of potassium, which is completely and passively absorbed in the upper gastrointestinal tract. However, before potassium moves into intracellular, where most of the potassium goes there, it has to pass through extracellular compartment. Potassium excretion. Approximately 90% of daily potassium intake is eliminated by renal excretion. About 10% is excreted in stool, and negligible amount is excreted in sweat. During metabolic alkalosis, or when there is an increase in arterial pH, a compensatory shift of hydrogen ions out of the cells into extracellular fluid. To maintain electropotential gradient, potassium moves from extracellular to intracellular. During metabolic acidosis, or when there is a decrease in arterial pH, a compensatory shift of hydrogen ion from extracellular to intracellular. To maintain electropotential gradient, potassium moves from intracellular into extracellular fluid. Both metabolic acidosis and metabolic alkalosis does not reflect change in a total body potassium, but a change in a distribution balance between intracellular and extracellular potassium concentration. Most importantly, rapid change in extracellular potassium concentration could lead to arrhythmia. Since acid-base abnormalities affect the reading of potassium but not the real body content, in case of acidemia or alkalemia, potassium level reading should be corrected. For every 0.1 unit reduction in arterial pH below 7.4, which is the normal level, roughly there is an increase or a fake increase which need to be corrected of potassium level by 0.6 milliequivalent per liter, with a range of 0.2 to 1.7 milliequivalent per liter, and vice versa. For every 0.1 unit increase in arterial pH higher than 7.4, roughly we need to correct the level of potassium by 0.6 milliequivalent per liter. In a clinical practice, we could apply a formula to correct for potassium level. The formula states that the potassium corrected is equal to 7.4 minus a patient pH recorded in lab divided by 0.1 multiplied by 0.6, and that plus to the potassium uncorrected, which is the result recorded by the lab. In addition to acid-base disorder, certain factors can cause transcellular potassium shift. These factors are: insulin can cause significant decrease in plasma potassium, while glucagon do vice versa by increasing plasma potassium. Beta-adrenergics cause decrease in plasma potassium, and alpha-adrenergic cause vice versa increase in potassium serum level. Hyperosmolarity increase plasma potassium. Aldosterone decrease plasma potassium or there is no change. And exercise cause increase in plasma potassium.